the people that are generally drawn to medicine are doing it for a greater purpose, right? It's a vocation, it's a calling, and you do it with the intention to help others.
Hi, I'm Dr. Keshishian. Welcome to our podcast series, House Calls with Dr. K. During this series, we're going to talk about many different things, but specifically, it's about medicine, the human side of medicine. We all have questions about our health, and who can you turn to? The providers that you trust. Hi everyone, welcome to House Calls with Dr. K. Today we're joined by three very special guests. The first voice you might recognize from two prior episodes. We are joined by Dr. Tom Shah. Hi, Dr. Shah.
Hi, Dr. Keshishian. Thanks for having me.
It's so good to have you back.
Thanks. It's great to be back again.
And who else do we have here today that you have brought?
Yeah, today we're joined by a returning guest, Dr. Tyler Wright, who's one of the fourth-year chief residents at the Outpatient clinic.
Thanks for having me. Good to be back.
We're also joined by a new guest, Dr. Naina Lalani.
Hi. Yeah, thank you for inviting me.
Dr. Lalani is one of the recent graduates of the internal medicine program here at LAC+USC and is currently working as an outpatient attending at County.
Thank you for joining us, everybody. Now, this is a very interesting episode because we have tried to talk about the resident perspective during this pandemic in a prior episode with Dr. Wright and Dr. Shah initially. And we're at a different place in your training and in the pandemic. And now it seems like forever ago when we did that episode. Following up today, we are definitely in a new phase of the pandemic, but also a new experience for all of you and how patient care has changed. Now, for the listeners, I think it might be helpful to go through the process of what it takes to become a doctor and the steps that you have taken in your career. Dr. Shah, explain us. We've graduated high school, then what ends up happening?
Yeah, what a long journey it's been. After high school, we do 4 years of undergrad, just like most people, and then we all do med school, which is another 4 years. And after that, we do continued training as residents. For Dr. Wright and myself as psychiatrists, we do 4 years of additional training. And for Dr. Lalani as an internal medicine doctor, she does 3 years of training. And then after that, we would be considered attendings or independently practicing physicians.
So at this phase, both you and Dr. Wright are in your fourth year, so your last year of residency training for your specialty of psychiatry. And Dr. Lalani just completed her residency training in internal medicine and is now practicing as an attending physician. So thank you for that explanation. That's a long journey. What changed this year during the pandemic, and how did the need for patient care and for doctors and nurses to be shuffled around, how did that change your residency training?
I think, at least what I notice a lot with the interns that I teach, they unfortunately, I feel like a lot of their training has kind of been immersed within COVID itself, because that's been so much of what medicine has had to deal with for the last year. And sometimes that takes away from kind of the diversity of trainings that you're used to, because so many of the hospital beds are just taken up by COVID patients. I think, I think with time, depending on like the circumstances in which you live, obviously, kind of the present diseases are going to predominate what you learn. But I do feel that, what I learned as an intern is definitely different than what the interns are currently learning, because they are so much better versed in how to handle this kind of emerging disease that's come about. But perhaps they haven't had the chance to look at some of the chronic conditions that we see so regularly, because people are avoiding hospitals or avoiding clinics as a result of the pandemic.
That's a really good point that you bring up, Dr. Lalani. As a new attending physician, you're not only a doctor, but you're also an educator. How do you kind of reconcile what you just said with your new roles and trying to give the interns a more well-rounded education?
Definitely puts kind of the onus on the attending or the teacher, right? Because I think because the diversity is a little bit more limited right now, just based on circumstances. You take whatever opportunity you can to actually discuss more chronic conditions. So, for instance, in the internal medicine clinics, when we see we do telephone visits a lot of times now. So if we see a condition, it becomes important for us to be able to give a well-rounded explanation of how it should be assessed in person based on physical examination, because I think that's probably one of the things that's affected most by the pandemic. So you do have to take out more time to kind of explain, in a normal circumstance, this is how you would evaluate for this condition. Because of the limitations of the pandemic, we're trying to assess, basically guess over the phone. That becomes more challenging. And so I think it does affect medical training to some degree. But, the hope is that, as things start to, as the pandemic ideally becomes better controlled, we might be able to introduce, the good old-fashioned physical exam again once more and more patients are comfortable coming back to clinic.
How do you feel like the interns have responded to this unique situation?
I think it's a really challenging time to train in medicine because, they've been kind of dealt a very, onerous burden, so to speak. And so but they've kind of risen to the challenge, and this is how they know medicine. This is how they've learned to practice medicine. And so they've done, an exceptional job in kind of adapting to the situation. And they do it kind of with a smile on their face, which is hard sometimes. And I think, as we all know, because we've gone through we're in residency, we've gone through residency, and we understand that one of the more challenging things about residency is just the sheer amount of work that you're kind of expected to perform. And one of the only ways that you have an opportunity to vent, for your own, mental wellness is to be able to have kind of camaraderie amongst your residents, even outside of work. And I think that's probably one of the things that's even more challenging for our residents is that, they don't get to socialize necessarily in the same ways that we would after work. And I think that obviously makes the pandemic even more challenging for physician wellness.
That's really great that you bring up not only the educational challenges, the job challenges, but also kind of the social challenges of being a doctor, especially in this difficult time. Dr. Wright, have you encountered similar kind of challenges in the psychiatric world?
Yeah, we've definitely faced similar challenges, but I also think a little bit more different. I mostly work in the outpatient clinic, the outpatient adult psychiatric clinic, so our patient population is 18 and older, and we treat a broad range of mental illness. The biggest challenge that we face is how to continue to treat our patients from a distance in a safe way. And that has been challenging with this particular patient population that's underserved and under-resourced. We have been doing a lot of phone visits, but we've also been able to successfully convert a lot of patients to video visits, which has been great. But that still has been quite a challenge. So it's just really challenging to provide the same level of care for the patients when you can't see them face-to-face, and even video visits aren't as good as doing in-person visits. So we're hoping that the pandemic will continue to improve as it has been over the last few weeks, and we can start to see more patients in person. But in terms of training, that also makes it very challenging because right now, even though we're still seeing the same types of mental illness and the same patients, you're just treating them very differently than you would in the real world in pre-pandemic times. So as Dr. Lalani said, it's a very different type of learning that is being experienced right now. It's kind of telemedicine and how to treat patients remotely as opposed to seeing them face to face. And in psychiatry, a lot of what we do is talking with patients, but there's also a really big component of being able to see patients and how they respond and how they react. And also, sometimes patients can have movement disorders, and those can be hard to detect using telemedicine. So those are kind of some of our challenges. And then, as she had mentioned as well, education is also very challenging.
Can you think of an example where having to do more telepsychiatry visits or video visits has really made it a new challenge for us and perhaps it made us need to be more creative in order to provide the same standard of care?
So another big challenge that we face is how do you deal with emergency situations in the outpatient clinic when you're doing it remotely? Like, for example, if a patient that you're speaking with says that they're feeling suicidal, how do you handle that situation? It can be quite complicated. Usually, how that's handled is the patient would be in the clinic, and we're able to safely obviously assess the patient, see how they're doing, and if they need to be placed on a hold, we can do that in a safe way. We have security. We can take them to our emergency department, which is very close to our outpatient clinic. We have a whole process for that. However, when you're doing it remotely, now you're in a situation where you're either on the phone or over video talking to a patient who is at an unknown location. You think they're at home, but that isn't always the case. So it's really important, and one thing we've adjusted is making sure you know the patient's location at the very beginning of the visit in case this arises. again, it's very rare, but there have been a few times this year where patients say that they're suicidal or had recent suicide attempts, and really our only option, because the SMART teams here in Los Angeles County are so busy, our only option is to call 911 and have a welfare check. So we call the police and we have them go to the house and evaluate the patient. But that can be still very complicated because you have to follow up with the police, which can be challenging, follow up with the patient, which can be challenging. And so it just creates like a lot of different dynamics. All the while you're still carrying your normal caseload, you still have to see your next patients. So it's hard because it's a lot more time consuming and the logistics are a lot more complicated.
Yeah, regarding the educational aspect, clearly, especially in your training, this is an opportunity that you haven't had before, getting a better handle of telemedicine, and it diversifies your portfolio and what you are capable of handling when you're practicing on your own. So that's definitely that plus. But then also the other side of it, like Dr. Lally was mentioning, is that the bread and butter things that you might normally see during your training isn't so much the focus right now. People are worried about COVID. They are worrying about different illnesses. They are stressed out. They're feeling anxious for different reasons, financially, what have you. And so what you quote unquote would normally see isn't necessarily what you're seeing today, which is a challenge, definitely.
Yeah.
Now, I want to definitely thank all of the heroes, and you all are heroes, and everybody taking care of our patients are heroes, but especially to those heroes who have taken on extra, more than. With the nursing deployments elsewhere, we've also had doctor deployments elsewhere. And we have the two of you who took on a really different role. Dr. Lally, can you tell us a little bit about your experience?
Sure. So I was basically called into the COVID ICU at Keck Hospital. It was for a short period of time, and it was mainly to assuage some of the burdens that the residents were having, being pulled on so many services because they're medicine residents, they're required everywhere, whether that's the wards or the ICUs, both at the county hospital as well as on the private side. And so in order to kind of prevent too many residents from being, pulled into a lot of different services, I volunteered to go in and take on the roles of a resident in the ICU setting again. To be fair, my training was in internal medicine, and part of that is learning critical care. So, even though I'm not a critical care or specialist or a pulmonologist, I'm very comfortable. I'm far more comfortable in an ICU setting than, say, another specialist. I think the main change was the fact that I was essentially taking on a resident role again, which is, I guess, more of a supporting role in the ICU. And so it's, things like, facilitating family meetings, writing notes on patients, gathering data for the specialists so that we can present the patients. So, in a way it was different to kind of change authoritative roles, to go from an attending kind of leading residents to, once again, myself being a resident, was a little bit of a change, but it was not something unfamiliar to me considering how recently I graduated. And the only other thing I think is the hours, right? So when you're in an ICU setting, the hours are much longer than if you are in an outpatient clinical setting. But that being said, if there's a way for me to contribute, during this pandemic, this was probably the best possible way for me to do so, to help both the residents as well as the patients.
How did it make you feel to be in that situation where not only are you going into an area that you didn't sign up to work because you signed up to be a clinic doctor and now you're back in the intensive care unit, but also you're, instead of being kind of the leader educator, now you're more of the kind of the hands-on doctor that you technically had completed training for already. How did it feel to kind of revert back into that position?
There was definitely some discomfort, so, I'm not, because I specifically chose a specialty that allowed me to be in an outpatient setting that isn't necessarily very procedure heavy, whereas an ICU is very procedure heavy. There are a lot of, lines that are placed in patients. There are a lot of, intubations and things like that. And so there, that was definitely out of my comfort zone, mainly because I, hadn't done it in, at least a year because I, had already kind of figured out my track and didn't necessarily actively pursue more procedures than I had to. But that being said, it was definitely, I feel like everyone that was in the ICU was very supportive. They knew that, this isn't necessarily something I do on a day-to-day basis. And so when it came to doing procedures like that, my goal became more supportive, and someone who, like the pulmonary critical care fellow, or perhaps a resident that's interested in going into critical care, they would take on, the task of doing the procedures, while my role was, again, more supportive. I think sometimes a lot of people would ask me when I was in the ICU, like, how does it feel being an attending and going back in a resident role? And I will say that, like, I did get a great deal of respect despite, playing more of playing more of a supportive role in the ICU. So, all the nursing staff and the residents still addressed me, with my title, which was probably unnecessary, but so did the attending. And so the pulmonary critical care attending was very thoughtful. He was kind enough to, ask for my opinion on things and also kind of share his perspective. So I feel like it was, I was very fortunate. I was in a team that truly worked as a team. And there wasn't really as much ego that was kind of or hierarchy necessarily. It was definitely, there's definitely a lot more a spirit where we're kind of in this together.
That's really great that seems to be the tone of coming together during these difficult times. I'm really curious you didn't have to do any of this. This is on a voluntary basis. What motivated you to help out in this way?
The residents who have been working countless hours, have missed vacation days, or have lost their weekends because they've been pulled for these services. You definitely want to help in some capacity. I am more fortunate than, maybe others in training because I, have a more fixed schedule. And I, when I come in the morning and leave in the evening, I can say, I know what's going to happen the next day. Unfortunately, the residents don't have that same sense of certainty as perhaps I would. So I think a lot of that motivation probably came, from the unique setting of my job, because it's both as a private practice clinician, but also as an academic clinician. And I think if I didn't see how hard the residents were working, or wasn't aware of it, then perhaps I may not, find that same motivation. And that, along with the fact that I recently graduated. So these are also residents that were, that worked alongside with me, that were my juniors at some point. And there is definitely a sense of camaraderie. So it's, you want to be able to help your friends because you don't want them to struggle alone.
It's really, truly inspirational, and thank you so much for everything that you've done. Speaking as an attending here on this end for psychiatry, Tyler, you let me know if we need to switch places at any time.
Noted. You ready now?
Right now, ready. And Tyler, can I just say that your experience is really unique in that you went back to medicine. And we as doctors, right, our training, we all go through the same medical school experience. And then in psychiatry, we do our intern year we have a lot of medicine. But after that, you're mostly in psychiatry, because that's your specialization. And you are now in your 4th year, you're a chief, you are fully focused in psychiatry. And tell me what you did.
I volunteered to be on medicine. I think I just missed it so much.
Oh, is that what happened?
The last time I was on medicine was with Dr. Lalani 3 years ago, intern year. It was kind of scary at first just because I knew it had been so long and I had forgotten so much. I think all of us in medicine have that experience where we've studied a ton for something, and then if you don't use it, you forget it. And even in psychiatry, I feel like there are often things I forget that I should know. It's just part of medicine. There's more things that you need to know than you have the capacity to remember. I really just kind of along the same lines as Dr. Lalani. I just felt this sense of responsibility, and seeing how our patients and my colleagues in the medicine side, just hearing these stories about how they're, just fighting for survival, just like our patients, to get through these wild times that we're experiencing. I didn't hesitate. I knew I had to do something, and I saw this as an opportunity that I could contribute. The least I could do is give 7 days of my time to help out on the wards, and I hope that I was helpful.
What was your experience like?
Well, I remember the first day I had a pretty bad headache at the end of the day. It was a lot. I went from working partially remotely and just working in the outpatient clinic from 8 to 5 doing psychiatry, which I'm comfortable with and have done for 4 years, to being essentially a fish out of water. I went back to medicine. I remembered very little. And, fortunately, everybody was super helpful, and everybody was very grateful that I was there to help out. But it was hard. It got easier as the week progressed. It's kind of like riding a bicycle. You kind of it comes back to you. But it took a few days.
So many specialties could come together and essentially work together. Because I think there is, as you guys might be able to kind of speak to, between specialties in a hospital, all specialties kind of gripe at another specialty when they're kind of, helping in a consulting capacity. There's definitely jokes that are thrown around. But I will say that for all of the specialists that have volunteered for medicine, I've never seen, so many specialists work so well together. And it was a beautiful experience to see that, so much of all of medicine actually came together, not just medicine, but even surgery. So many people have come together and stepped up to be able to support internal medicine, which unfortunately, just by nature of our specialty, this is the lion's, they had at least initially been given the lion's share of the responsibility for this pandemic. But, I think the nature of medicine is such that the people that are generally drawn to medicine are doing it for a greater purpose, right? It's a vocation, it's a calling, and you do it with the intention to help others, right? And that includes your colleagues.
Absolutely. And I wonder if you noticed that, Dr. Wright, if there was a lot of psychological issues that were coming up with the patients or the providers while you were working in those stressful situations.
Yeah, a lot of, with the patients as well as the providers, people, were dealing with this in their own way, whatever that may be. A lot of the providers I worked with, and, they're experiencing a lot of burnout. People aren't getting a lot of time off. They're working long hours. It's minimum 12-hour days, and it's busy 12 hours. They barely have time to stop and eat lunch. And so, and the caseloads were very high, and there's a high acuity. There was a lot of transitions between placing people in the ICU, and there were frequently some code blues. It was a very stressful environment. So not only are patients dying around you, but you're working long hours, and it was very stressful. So, I can't imagine having, I did 7 days. I can't imagine having that be my day in and day out for months on end. So, truly, my hat goes off to all these medicine residents who are dealing with this on a daily basis, because at the end of the day, I got to leave and go back to psychiatry, my field, which is still stressful, and we're dealing with a lot of patients going through a lot of crises, but it's very different. From the patient side, yeah, I did see some patients with a history of mental illness, and as we frequently see in our outpatient clinic, a lot of these patients, their mental illness is exacerbating or worsening because of the virus. People are isolating because they, obviously can't go out, and people are worried about getting sick, especially in the hospital setting. So I think those things definitely came up during my week.
Thank you for providing that perspective, because sometimes I feel like the medicine residents have been doing this for so many months that they're not even able to describe what kind of their day-to-day life is, because they're so used to it. But for you, Tyler, as someone that's not in internal medicine that can join and actually see what that it's like, you provide a really good perspective for everyone else to kind of understand the day-to-day difficulties.
It's a little insider here. We did an episode about vaccine hesitations with our clerical supervisor, Miss Walker, a few episodes back, and it was interesting that what she mentioned was the reason that she decided to get the vaccine at the end of the day was because of Dr. Wright's experience on the internal medicine ward, and the fact that he had shared what he had seen and what he had experienced. And I couldn't wait to tell you that, Tyler, because it was, you had made such a difference, just like with Dr. Lally and everybody else. You've just made such a difference in everybody's lives. And I wonder, after hearing the episode, because I kind of made you listen to it, what were your thoughts about what Ms. Walker had said?
Yeah, I think I at first was like, wow, I remembered the conversation because it wasn't too long ago. I just couldn't believe that it had that much of an impact on her. And I felt very touched that she really took what I had to say to heart. And I'm glad that convinced her to get the vaccine, because I think, I really think that everybody who can get it should get it, because you never know what's going to happen. You would see, just working on the wards for a week, you see it. These people didn't expect to get COVID, and here they are on high flow nasal cannula and max settings, and there's no ICU bed, and they can barely breathe. It's just what we're going through right now is just, it's hard for everybody. I'm just very touched, and I'm glad that Diane was able to get her vaccination. I was very happy. And I actually followed up with her. She said she was able to convince 6 family members to get it as well. So I thought that was pretty special, since there was a lot of hesitancy there, which, after hearing her story, is very understandable. So.
Thank you. And Dr. Lally, I'm sure you've had a lot of similar type experiences where the work and what you've contributed has meant so much to so many people. I wonder if you can share one of those special moments with us.
I will say that, like, even when I volunteered for, the ICU, in the ICU setting, I had, when I had family meetings with a lot of these patients' family members, unfortunately through Zoom, when I introduced myself, or when I was introduced by the palliative care team, they were like, oh, you're volunteering. And the first thing that all of my patients' family members would say would, we're so grateful that you're there. And, we're so grateful that you're able to take care of our family member, even if they were in the most, precarious of circumstances. I think patients in general are patients and their family members are generally very grateful for the medical community and how much we offer, even though there are a lot of frustrations with, what is going on currently in terms of the availability of resources. In terms of vaccine hesitancy, or maybe changing someone's opinion, I will say that by and large, the patients that I have met, both through the county setting, which is generally a more underprivileged population, as well as on my private side, everyone is clamoring for the vaccine. I think people, especially people who have family members that they know of or friends that they know of that have contracted the infection and unfortunately had a more serious infection, I think they're all aware of the dangers of the infection. And so most people are very willing to get the vaccine. I think a lot of questions come up, especially with pregnant females, because I've also volunteered at the vaccine clinics that we have at the hospital. Sometimes pregnant females will come up and say, I don't know, like, is it safe for me to do this? And oftentimes we say, you should talk to your gynecologist. But by and large, even gynecologists will tell their patients, you should get the vaccine. Even if we don't have adequate data, based on things that we can, extrapolate from subunit vaccines, information that we can, extrapolate from that perspective, you are safer having been vaccinated than not. And so I feel like, although there is a great degree of vaccine hesitancy, especially amongst our underprivileged population, I haven't come across it, as much. I don't think I've ever had to do much convincing for anyone. Most patients kind of jumped at the opportunity to get a vaccine.
Thank you for that. And thank you for the information. That's really helpful.
Ended?
No, I'm just curious if you had other questions. I didn't want to be the segue.
Okay. I really want to thank you guys once again, Dr. Lalani and Dr. Wright, for being superheroes and kind of stepping up to the plate during the time that we need you guys, and providing what I think is a very, very important perspective. We're at a point where we've crossed 500,000 deaths in this country, and it's easy to say that, yeah, that's a large number, but behind every one of those deaths is a story here. It's a challenge. It's a team of doctors that's trying to save their life, that's having these difficult conversations with families, and family members that are struggling to deal with someone passing away. Every one of those 500,000 is a person that has their own story, and it's really important for us to kind of realize that and to see that. And I think having this conversation here today has really helped give life to some of that perspective.
Absolutely. And I want to thank you all, and thank you, Dr. Shah, for coming back and helping facilitate this discussion. I hope that in appreciation for the residents and obviously all of our colleagues, but as resident appreciation time is approaching, and we want to acknowledge all of the work that our trainees are doing, that this is an opportunity to just give a glimpse of what some of our superheroes have done here today. And thank you, Dr. Lally, for joining us and going back to residency. I don't know what to say about that. I'm still in awe. So thank you all.
Thank you for having us.
Thank you for tuning in today. Make sure to follow us on Instagram and Twitter, and to subscribe to the LAC+USC Medical Center YouTube channel, where you can find all of our previous episodes, in addition to the episodes located on anchor.fm/House with Dr. K. We also want to hear from you, so email us at lacuscpio@dhs.lacounty.gov. Thank you for tuning in, and see you next week.